endotoxins during the autoclaving process. Meibomian secretions have to be taken care of before you take up the patient for a LASIK surgery, because that's another cause which can trigger off a whole attack of DLK. The machine cleaner oils which we use in the microkeratome. Now these are something which are not looked at, because what happens is most of the time the microkeratome are handled by our staff, and very often they are not really washed off from the microkeratome. So it's important that the machine cleaner oils, the WD-40s, everything which is used is cleaned properly before starting the surgery. Any epithelial defect, surgically induced or due to trauma or due to a recurrent corneal erosion syndrome, can also trigger off a DLK. Excessive femtosecond laser energy, when we create a femtosecond flap, is another cause of DLK, and therefore whenever you are doing a femto flap, it's important that the energy be titrated to such an extent that the least possible energy is used so that the flap can be lifted. Other causes of infectious keratitis, like either bacterial or adenoviral or due to herpes simplex virus, are also known to give rise to DLK. Now, the DLK is basically graded from grade 1 to 4. Grade 1 usually gives rise to a very mild keratitis, which is usually in the periphery, hardly spreads to the center. There are no symptoms. They are usually picked up on routine visits post LASIK surgery. The treatment here would consist of topical steroids, usually prednisolone eye drops, 1 to 2 hourly, and the patient needs to be followed up every 1 to 2 days. In the grade 2, what happens is the infiltration starts spreading towards the center, and there is a fair amount of decreased vision and or photophobia. Now the treatment here will consist of not only the topical steroids, but also systemic steroids in the form of prednisolone, about 60 milligrams per day. Depending upon how heavy the infiltration is, one should consider lifting the flap and washing, especially if the infiltration is spreading more towards the center. And these patients need to be followed up on a daily basis. In grade 3, what happens is the infiltration is much more than grade 2, and there are clumping of infiltrates, especially in the center, and this gives rise to an obscuring the iris details. Now this, on the whole, can cause a considerable amount of visual loss. So the treatment here, in addition to the local and systemic steroids, would also be lifting the flap, and not only just giving a copious wash, but also scraping the undersurface of the flap as well as the bed, either with a Merosil sponge or scraping it with a blunt spatula. In case there is a doubt of any infectious condition, then it's better to culture the scrape which you have taken. And again, these patients need to be followed up daily. In the grade 4 of DLK, the infiltrate is really dense and white. It can occasionally occur with corneal melting, and the vision really falls to a significant extent. The treatment here should be an immediate flap lift with scraping the interface, culture, a copious wash, a steroid drop on the stromal bed, and then continue treating with the topical as well as systemic steroids. And most important, last but not the least, pray for the patient and pray for yourself. These patients also require a daily follow-up. Now there are certain conditions which need to be differentiated from DLK. The first of these is what is called a CTK, or central toxic keratopathy. Now originally CTK was thought to be a severe inflammatory form of DLK. But now it is believed to be a rare non-inflammatory condition of an unknown etiology. It is seen not only after LASIK, but also after PRK or SLTs. The symptoms here is just poor vision and photophobia, and the signs are basically consisting of certain mild to severe corneal opacities. There is thinning and flattening of the cornea, thus giving rise to a hyperopic shift and anterior corneal striae. Now here steroids are usually not helpful. This is a self-limiting condition. It usually improves within 6 to 18 months, and therefore it's very important not to enhance these cases because of the hyperopic shift before 18 months. The other condition which mimics DLK is a pressure-induced stromal keratitis, or PISC, which basically is due to an elevated intraocular pressure. Now these patients are usually steroid responders. Being steroid responders who are on local steroids following the LASIK surgery, they mimic a picture of a stromal keratitis. Usually these are the cases where the IOP is not checked, and the steroids are further increased in order to treat the misdiagnosed DLK. So basically what happens is there is a corneal haze, there is a fluid cleft which is seen in the on a OCT. So this is a classical fluid cleft which is seen in the OCT. So the prevention of this condition would be to check the IOP 1 week post-op, especially with the tono pen, not only in the periphery but also in the center. Because what happens is because of the fluid cleft which is formed, you can get a falsely low intraocular pressure. Treatment here would consist of stopping the steroids totally, unlike in case of DLK, and then treating the intraocular pressure like you would normally treat a case of glaucoma. So in conclusion, DLK, which is an inflammatory response to the cornea, has a fairly good prognosis if it is detected early and if it's managed promptly. The incidence and severity has been decreasing due to good pre-op and intra-op care, and it is important to differentiate these from other conditions like CTK and PISC. Thank you for your kind attention.